welcome everybody to another VITA Learning webinar. Today we're featuring Mr. Mark Wagenseil. He's going to give us an excitement, rally of dentures, how to utilize dentures, freedom of movement introduction. What does that mean, and why should you care? So welcome, Mark. How are you?
Hi, good morning. Hi, everybody. Super duper, especially now that you all are here.
Excellent.
I'm going to speak Canadian. I'm going to speak Canadian American, eh?
Yeah. So is it still cold up there?
It's warming up now. Yeah, it's getting better. It's slightly above zero, or above freezing, so it's getting there.
Oh wow!
Just really icy.
Without the wind chill factor, right?
Yeah, it's really howling today though. So.
Yeah, good for making igloos.
Yeah, thank you. Yes, indeed.
All right. So again, welcome everyone. Today we are going to go over some denture concepts with Mr. Mark Wagenseil. He is a denturist, so you're going to learn a lot from him. If you have not attended Mark's webinars before, this is going to be a very dynamic, exciting webinar, I'm sure. So before we go too far, I just want to let everyone know that has registered, your phone is on mute. So if you want to ask a question on that panel that pops out on that right side of your screen, go ahead and type in your questions there. And then at the end of the program, we'll have a Q&A. And if something comes up where we need to stop and ask Mark to elaborate or to clarify, we'll do that as well. But please send in your questions so that we have some very attentive questions that you really want to know and you're too scared to ask it in the past, or you're not sure about something. Please ask. We want this to be very interactive with you. That's the whole purpose of these webinars, of the education side of the business, is that we help you to help yourself. And Mark's a great, excellent resource to provide you with the answers when possible. The webinar itself will be recorded, so you can always visit it later on our VITA Learning website, the VITA YouTube channel, and so forth. Give us a couple days and then we post it. There is no CE for that on the website when you review it. However, for this program today, you that have registered, if you're looking for CE, we will send you a follow-up email from our VITA Marketing Education Department just to make sure, confirm all your information to give you any CE hours that you'd like to get, okay? All right, so today, freedom of movement, introduction. Why should you care? So, Mr. Mark, I will leave it in your capable hands. And just a little bit about Mark.
Who am I?
Mark is a VITA Global Certified Trainer and Management Consultant. He's a licensed denturist, which is really good because he comes from a concept of actually seeing the patient, the end result, and it brings so much more insight, I guess, into making it correct. And the principles that you follow, Mark, I think it's demonstrated in your practice itself. That you've been a technician over 30 years with experience. You own and operate a heritage denture center in Edmonton, Canada, and you have as I mentioned, your own clinical denturist practice. Mark has spent his career focusing on how the dentures integrate in the mouth and body, and he inspires a unique awareness of occlusion and professional growth of technicians, dentists, and other denturists. So I will leave it out on to you, Mark. So
thanks, Jim.
All right.
We good to go? We're good to go. All right.
I will switch you over.
Oh, hang on. I am
you
the
are
boss
now the presenter.
I am the boss now. Whoop, whoop. Hi, everybody. Good morning. Whoop, whoop. We do not slap teeth together with dentures. We do not slap teeth together. Yes, good morning. I am definitely awake today. Thanks for joining me. Thanks for investing in yourself. Thanks for spending time with me. Good morning. This is about patient care. This is about self-care, and this is about our patient that trusts us, whether they trust us directly as a wet-fingered practitioner or through a dentist, and we are the lab building the denture. There's a patient at the other end of this that trusts us and the family and the unit that's supporting them, and we are all part of that family and that unit. So thanks for joining me. This is I'm going to call it an introduction back into freedom a little bit, and why you should care. We're going to spend the next little bit of time. I am 52 years old. I started caring for patients and into the lab industry when I was 17. So it's been now 35 odd years of my life doing this. And gosh darn, it's the right, I just said gosh darn. See, I'm 52. This has definitely been the right career path for me, and it's been good. I'd like to be honest with you. I spent the first probably 5 to 10 years banging my head on the side of the wall here, because what I was taught in school, the procedures that I was using wasn't working all the time, and patients would be coming back to me with repetitive problems, and it was frustrating because I thought, geez, is this all I have left? So thank you. I want to share with you my journey and some of what I've done, my tremendous OCD to try and figure stuff out, and I want to share with you, that and that journey. So let's get started. I want to do a little bit of a PowerPoint about being a superhero for your patient, because that's why, and why you should care about freedom and movement, and some of what I'm going to impart with you today. So the first question I have for you is why? Why are you here? Why did you become a denturist, dentist, prosthodontist, dental lab technician? Why did you do it? What drew you to this first off? What was that joy and that intrigue that brought you here? You wanted to probably help people. You liked working with your hands and building something. Certainly you can be creative. In some cases, you wanted to be your own boss, being able to build something from start to finish. If you have that ability, especially as a denturist, you can see it. Personal interaction with patients, you wanted to do that. You liked and you were caring. It's technical and challenging. So think, why did you become what you are today? What drew you to this? Try to think back to that. And of course, now, as I alluded to earlier on, our common denture issues then that we face from a denture perspective is denture teeth break, chip, and pop off the denture. Especially, it's always fun when that happens in the first few months of a new denture, regardless if it's implant retained or not implant retained, or digital or not digital, etc. Patients get a little cranky when things break within the first year, rightfully so. You can't chew well with the new denture. Then this is always a good one. Mark, how come the new dentures are looser than the old ones? That was always a good one when a patient is asking that to you. You've relined the denture with multiple relines with no success, so you get the work order from the dentist, and it says this is the second time or the third time we've relined this denture this year with a sad, smiley, upside down smiley emoji. So those are always fun to get. Denture base breakage. Food collects under a denture, but we don't know why, or we don't need to reline because we check it and the denture fits, but the patient says, well, it's still loose. The new denture feels too big. They don't like it. Soreness, of course, and a temporary implant denture is preferred over the permanent one. I was watching television again yesterday evening, and I can't remember the channel it was on, so forgive me. However, gosh darn, again, there was denture adhesive commercials on there. And so with, time fit technology and all of this, and the denture adhesive market in the United States alone is about $150 million a year market. Boy, do you got to sell a lot of denture adhesive to make $150 million. So, people get frustrated and then they give up and they go to the glue to try and help them. There's still advertising for it, so they're still making money at it. And this was my journey now to understand why were these common issues coming to me, because I was doing it right. I was doing what I was taught. I was doing what the textbook or my colleagues or my instructors said, and I was still having these problems. And I thought, well, wait a minute, my bite's right. The denture fits, there's suction on it, in my opinion, what's going on? And so, of course, we get really good at the excuses and telling patients, well, it's just a denture. Well, it sits on gum, what do you expect? These types of things, or the famous, you don't have a ridge, it's terrible, so it's not my fault, it's yours. So these were things that myself included got really good at saying. And I took pause because I thought, I'm 5 or 10 years into this profession and professions, and I thought, this is it. I've got the dentist sending me stuff back to the lab going, well, this isn't right, and oh, it's a processing error, Mark. Well, okay, how many processing errors do we really have, everyone? And so I just thought to myself, what's going on? And so began my journey. And these complaints pile up. And day after day, today included, tomorrow, you have to look at this from an holistic perspective where they start to pile up, and we deal with it over and over and over again, little by little by little. And this builds up stress for you and I, okay, as individuals, and that we have to deal with, or we're on the phone to the doctors repetitively with similar troubleshooting problems, or you're dealing with the patient that's staring you down going, how come this is happening? This shouldn't happen. It's a new denture, it should fit. These things cause us stress. This stress builds over time and it leads to burnout. And I want to talk about this because we don't talk about this in our professions, and it's time that we do. Professional happiness. In 2019, the World Health Organization has now officially listed burnout as a disease. Burnout is classified as feelings of energy depletion or exhaustion, increased mental distance from your job, or feelings of negativism or cynicism. Now, I want to bring up the cynicism because when I travel around and I go to conventions and I listen and I sit in the side and listen, you can hear it. Oh, the patient's crazy. Oh, the patient's unrealistic. Oh, they're nuts. We blame the person. We blame the patient. And we get cynical at our jobs because we're frustrated because of the repetitive problems that we face every day. This is about getting control of our common issues. Reduce professional efficiency. And disruptive sleep, if you're not sleeping well. This is a major sign of burnout. You go on a holiday, even a long weekend, you come back, go to work, and after one or a few days, it feels like you've never had a holiday or time off. My dear colleagues, you're suffering from burnout because you're right back in it and the time off wasn't enough. This is a major sign of burnout. We need to address it for yourself, and acknowledge that it's there. So that's the first thing to do. We have to take control of the situation so that it's multi-phased, because you have to look at your own personal life, the stresses that are there. But I want to concentrate on the denture side of things, of what you face in the office and in the lab every day. This is about getting a hold of it. So I'm going to talk about a few different things. I call it like a pie. There's different pieces and slices of a pie. I'm going to mold this all together for you, so that you have an understanding of my journey and what I did to bring some of these under control. So what's under control is the repetitive, cracking and breaking and fracturing of denture teeth and denture bases, and the adjustments and the sores. If we can get a hold of that, then that's really important. So bear with me as we go through this. I've experienced burnout, and I've seen it now through my travels globally. It's faced globally by us in the denture profession. And this was my goal, was to explore this and break this apart for you. So the first off is the central nervous system. It learns and functions on patterns and repetition. So the patient has to learn on patterns and repetition. And they learn on how to eat with a denture, and the brain learns a pattern. So then when they come in for a new denture, we inadvertently change that pattern. yet we don't consider the consequences to the central nervous system, and can that patient adapt to those changes? So the first thing is you have to look at a person and say, do you think that they can adapt to this? Now, in some cases, we don't have control over that in the lab, but we can on the back end of things when there's problems. And you have to ask the doctor then, how much, tell me about the age of this patient, or how are they frail? Are they not frail? Can we learn a little bit about the person that the plate went into? Because remember, when you change things, you change the pattern and repetition. Now, if I know from a dental technician's experience, when I see, say, the new denture come through, the work order for the new denture, and say they made a mold of the old denture, and I see that it's very worn down, then I know going in, I can say to myself, hey, this is going to be a big change for the person because the existing denture is worn down. Now the doctor's probably opened the vertical, and now we're going to put new teeth on. So it's quite a change. So there are some things you can do from the lab side to try and, again, make this fit better and adapt it to the person, even though you've never met them and even though you've never seen them. What you're trying to do is put a hold on how many times that case is coming back to the lab for the unnecessary relines or the breakages or things that we can try to get a control of so that they don't happen. What you're also trying to do is stop the adjustments and the follow-up care for the doctor, because then if he puts the denture in and it fits, then they think they're doing a great job. And of course, then that happens to have the spin-off to the lab that the lab is doing their part and their job. And as a denturist, we're trying to get a control of our adjustment rates as well, or as a doctor, we're trying to get a hold of our adjustment rates, which I'll get into a little bit more. The central nervous system is subject to degradation due to age, health, and medical conditions. So as we get older, the central nervous system isn't as sharp and keen anymore. There is no nerve to denture teeth or the denture. And we do forget about this. I've looked at patients at the beginning part of my career and I've said to them, bite together, touch. Well, Mark, you idiot, how do you know if their teeth are touching together? They can't feel their teeth. They don't feel their teeth touch like I can with real teeth. You forget that. How does the patient know that their teeth are touching or that their teeth are coming together properly? All they can explain to you is, well, it's not fitting and it's hurting. But I look at it and go, well, yeah, it does. It fits. The extensions are good. Oh, I've covered the retromolar pad. I'm doing all these technical things, but the patient is saying, yeah, well, when it's functioning in my mouth, I feel these things happen and they're not working. But they can't feel the problem with the teeth not functioning together properly because there's no nerve to it. That was one of my big aha moments when I figured out that, geez, you can't feel with denture teeth. So how does a denture patient feel? Well, they feel the hydraulic pressure upon the ridge when they touch. So the first thing to remember is they feel when you touch your teeth together to swallow, there's going to be so much pressure down onto the ridge. So the brain knows, I've swallowed. Then there's hydraulic pressure upon the ridge during chewing. Now there's more pressure. So the brain and the central nervous system goes, oh, I'm eating. I'm putting pressure down, and it learns to understand the difference of pressure. So when I say to a patient, touch, bite, then what they do is they're trying to feel that lighter pressure on the gum, which tells them, your teeth are together, because that's what the brain has learned in that pattern. So when you build a new denture, that pattern can change. When you change the vertical, that pattern can change. The compression can change. So the brain needs to understand these changes. The only way it's going to do that is practice and time again after the insertion. Muscle memory, so the masseter muscles, temporalis muscles, the main closing muscles in the mouth, they also have a muscle memory to them, so they know at certain heights and positions when they close or function. You change the vertical, you're changing that muscle memory as well. And as now when we take dentures and we sit them on a bar and such, now you're taking away the hydraulic pressure feedback. So you're relying more on muscle memory for the patient to close and bite together in Centric properly, because now you've taken away the hydraulic pressure feedback that they may have experienced from previous dentures prior to implants being placed. You need to consider that in your treatment planning. So we expect a patient to accurately find Centric each and every time they close. So we expect them to bullseye in like it does on an articulator for us in the office. We expect that every time from someone. I am here to say to all of you, dear colleagues, that is impossible to do every time. To bullseye land something every time is not going to happen. So what happens is we're asking somebody to land in Centric and bullseye that sucker. It's not going to happen. We set teeth on an articulator with this in mind. We get it perfect in the lab. We get it perfect in the office. And then we send it out into the real world, and we wonder why we have the complaint lists that we do and repetitive complaint lists that we do. And then the cynicism that goes with us being burned out from dealing with this all the time. It's not possible for a patient to do this every time. There's no nerve into the denture or denture teeth for them to accurately understand where they're biting. So please understand that. So we need to add compensation in, and this is now about my journey with you to share that information and how do you do it. Okay, so we're going to get to it. When you don't find Centric, you hit and slide into the position. So the hit and slide is the problem. The opposing cusps land on the guiding inclined planes of usually of the lower, and it slides into position. But the patient can't feel the hit and slide because there's no nerve there. What they do feel is that the denture rocks because it's the slide and the hit, and it rocks the denture base. So that's problem number one. Okay, and then that causes the rock of the denture base. So what is freedom in Centric? By definition, it's a flat area in the central fossa of a tooth, usually the lower, in which opposing cusps come into contact, yet permits a degree of freedom in eccentric movements uninfluenced by a tooth incline, which means they can touch together, but it's not locked. There's a little bit of wiggle room there. So the real life example. So bear with me as I switch. Can you see me now? Okay. So we can't feel the denture teeth. So we ask a patient to bite. They're looking to find the compression and the hydraulic press to tell them that their teeth are together. Okay. Yet we use denture teeth that are locked together. So bear with me. So right now, when I touch my natural teeth together, I can touch. Now I can touch them together in Centric, but now I can wiggle them in Centric. Before I go into eccentric movement, so I want you all to try this, please. So you touch together and you wiggle in Centric before you go eccentric. So let me show you again. So there's eccentric. No, you can just see it. There's a little bit of wiggle in Centric. That's freedom. Everybody, I'm again introducing to you if you're new to this, and if you're not new, this is the Waggin' So Wiggle. So everybody wiggle. This is freedom, and freedom is good. We forgot about this. Freedom is good. Most denture teeth on the market do not have freedom in them. When they go together, it's locked in. Yes, they work in balance, but there's no freedom, no little bit of wiggle room in there. So you're asking a denture patient, and in most cases, a senior citizen with degraded muscle memory and neurological function, to bullseye land every time. Then stick food in their mouth and expect them to bullseye land every time when they can't feel their teeth. Yet we expect this from them. This is freedom. Freedom is good. We forgot about this with denture teeth. So the real life example now translated onto the picture is we need to be able to land in that little green zone. It's that little freedom zone. If you don't, you hit and slide. So what did I realize is the hit and slide causes all the problems. But they can't tell me it's hitting and sliding because they can't feel it hit and slide. Regardless if it's an implant denture, traditional, digital, it doesn't matter. Yet, what are the results of the hit and slide? The breakage, the damage, the chipping, the sores. So what's a denture sore? Whoops, as I switch, whoa, where did we go? What's a denture sore? Remember I said the denture rocks? So if there's a hit and slide, it rocks the denture base. So then the patient comes to the office and they say, my teeth are loose. They come out, they're loose and the food gets under it. It's because the denture base is rocking. What do we do clinically? So for all the technicians in the house, woot woot, all you guys, woot woot, give yourselves a woot woot. What we do clinically is we take our fingers and I go down and I push on the lower denture, for example, and I'm pushing in and around the first bicuspids or the first premolar area, and I'm checking to see, does the denture rock and rotate on the gum structure? I expect to see some compression because I'm pushing on soft tissue. If it does this and I can wiggle it, so let me line up to the camera. If I can do this and this, then yeah, it probably needs a reline because the gum has changed. But if it's holding pretty firm and it's not moving, then I'm going to say, oh, it doesn't really need a reline. And then I ask the patient, well, okay, touch together and swallow for me. And then I take my finger and I put it on the lower denture and I push right there. And when I push, and then I can hear the little of the suction, well, it probably doesn't need a reline. So what's causing it to move? Well, it's the hit and slide, and the denture's doing this. So we're walking like a penguin, and now it's moving this. What does that do? Well, it lets food underneath, so they say, oh, it's loose, and because I'm getting food underneath. So what does denture adhesive do? Is it forms that seal barrier around there that's blocking the food from going underneath it. Okay, so that's what adhesive does. This rock motion is doing what on the gum? So imagine the denture base as it's doing this. What's it doing? Can you hear this? Whoop, let me go to the right side. What does this do when you hold your hands together and start doing this? It creates heat, and heat causes the blister on the gum or the white spot that we see on the tissue, and that's a burn. So let's call it like it is. So the denture irritates the gum, causes friction, friction causes heat, heat causes the blister and the burn of the tissue. So that's what a denture sore is. So we have to be careful because, again, the patient can't directly feel it. We misdiagnose the sucker and don't think of the hit and slide because the patient isn't telling us it's hitting and sliding. It's masked. And on an implant bar treatment, it's your responsibility to protect the temporomandibular joint. And that falls on all of us. Because if there's a problem with the bite and there's that hit and slide, you're going to damage the temporomandibular joint over time. And that's usually misdiagnosed at first because we get ringing in the ears, pain behind the eyes, neck ache, backache, vertigo sometimes, and we don't realize that it's the degradation of the joint. So this is what freedom looks like on denture teeth that have it. So I've lifted the buccal cusp out of the way, and what's happening now is you can see that's full eccentric movements, so our classic working and balancing, but now you've got the wiggle in centric. So I have an articulator that can do it, and now I have denture teeth that can do it. And what it's doing is it's permitting that degree of freedom because we can't bullseye land centric every time. So what am I trying to do? Control the hit and slide. I'm controlling the hit and slide by using denture teeth that have freedom and centric in it, okay? So which ones have? Well, so let's have an open and honest discussion on that. Number one, VITA has it, but not all of their lines. Freedom and centric has been introduced and incorporated into denture teeth more recently. So Lingoform has it for VITA, MFT has it for VITA, and PhysioDens has it for VITA, as well as the Vigo and Bionic for the digital aspect, okay? Ivoclar has it, but not on all of their tooth lines, only more on the Veneris lines and the more recent lines from that. Mertz Dental has it in the Article product, so that's more recent as well. And that's a pretty small list. Candular has it as well. So it's not a big list, everybody, of denture teeth that have it. So as I speak freely here, and this was something that I had to research and learn. It was difficult because was not normally talked about. So when you ask a sales rep about freedom and centric, most of them aren't versed in that. They understand that the teeth work in balance because that's what mainstream dentistry and dental technology has said was teeth need to work in balance, but we forgot about the wiggle and we forgot about that little bit of wiggle room. So it's been a process for me to see that and to understand which denture teeth have it, and that's now I use Lingoform on everything, and it has significantly impacted my professional career and the adjustment rates and the problems, which is why I'm here talking about it, to share my experiences with you. So first off, not every denture tooth has it. The other thing I want to talk about is classic 10, 20, 30 degree occlusion. We were all born and raised on it, so to speak, and that's a standard in our industry. Would you like you to understand that technology of that working and balancing occlusion, the teeth are quite together, they're quite knuckle tight on those types of occlusal forms. And they have to, it's more of a milling tooth, which I'll get into in time through our presentation. But I want to say that the 10, 20, 30, 33 degree occlusal concepts that are widely used globally now all originated back in the 40s and 50s, at least, if not older. So those concepts have been with us for a long time. So as I speak freely and contentiously now, as this is being recorded for posture for eternity, it's not 1950 anymore. What technology are you using in your own life from the 50s, other than a handheld can opener, which now just has a bigger handle than the little metal ones that they used to have? So we've done a more ergonomic handle upgrade on it. But what else in your life is from the 50s and the 40s? What? It's not a big list, everybody. Why are we using denture teeth from the 50s and the 40s? Honestly, it's time to move on. And that's why you're here, because I'm going to poke you. I'm going to challenge you to think about this differently. So thank you for your patience with me as I do that. Chew cycle. So this is a video of people chewing. This is with natural teeth that have nerves and they can feel. So this is an apple. Watch the patient chew. What do you see? The jaw does not open up straight up and down. Look, it comes in at an angle, and it comes in at a, you can see it's almost like a teardrop. It's not straight up and down. It's got a motion to it. Here's a piece of carrot. Same thing. Look, it's coming in at an angle. Where's the food? Most of it sits on the main molars, the first and second molars. And you can see the tongue is rolling the food and the jaw's coming in at an angle in a chew cycle. Now, this is a little difficult because, of course, they have lip spreaders on, so it's a little hard for the patient, but you can see there's a motion. You can see them with gum. It's even better now. It's a fluid chew motion like a teardrop that comes in. And you can even see, if you look carefully, it touches in and it goes freedom and centric and then opens. So they're not landing exactly. There's a little bit of a gap. You can see the little bit of freedom in there. Now watch this patient. Watch their chew cycle. You see how it's different? It's more vertical. You see how it's a little bit more up and down? And I'm going to pause this video because I want you to take a look on the left-hand side of your screen. And you see the premolars? You see how they're tipped like that? I mean, we'd never set that in a denture like that, but we can do that here, and the edges and the buccal inclines aren't chipping off this person, because even though the teeth are chipped, or excuse me, even though the teeth are angled with the neck out, the chew cycle has incorporated itself to function within those limits of that person. Isn't that neat? So now each person has a chew cycle. So this video goes on for 22 minutes, so we're not going to watch that for 22 minutes. A chew cycle influences tooth interaction and function. So what happens in a chew cycle is that we have interference points. So those interference points where the hit and slide can occur is the buccal upper, lingual lower. Now, we should not have contacts in that area. But you're saying, but Mark, wait a minute, I went to school and we're supposed to have buccal upper, lingual lower contacts, and that was drilled into our heads. So I've got my head in my hands right now, in case you can't see me, because that I left that theory behind. It's not the 50s anymore, everybody. So we don't want the hit and slide anymore. That's what's causing our problems. Right there in the red marks. We don't want that. I don't want contact there, because and I'll get into this more to explain it, so bear with me. A chew cycle is either flat, oval, ovoid, or teardrop. There's different kinds. So like a person has a fingerprint or a retina scan unique to that individual, they have a chew cycle unique to that individual. And we have to learn to identify it and then set teeth to function within it. When you catch that and you can make them function like that, your problem list will go down, which means the repetitive problems that we see every day will diminish significantly. Now, as a denturist, I get to see the patient directly. As a doctor, you get to see it. As a prosthodontist, you get to see it. But as a lab technician, you might not get to see it unless you work in an office that you have direct contact and you can walk in the op and see the patient. It's hard to identify. And so I'm going to show you some tricks to try and identify it, because that's part of the freedom process, is learning to identify the chew cycle. So a flat requires a little bit more freedom in Centric because their chew cycle is flat. What's going to happen is the buccal upper and lingual lowers have a higher chance of catching and interfering because the patient has a flat cycle. Now, why would a patient have a flatter cycle? On a denture situation, when they wear their teeth out, their teeth are flat. Are you able to chew food, with flat teeth? Yes, but you have to mill it. To mill it, you have to touch together and slide on it. So they're going to flatten their chew cycle with denture teeth that are flatter. When we rehabilitate it, that's not going to work, because now they have to go back to that teardrop style, because that's how the teeth are supposed to work. That explains why patients would come to me and say, Mark, how come my new teeth are looser than my old teeth? Because the occlusion was rocking it out, because they're trying to do more of a flatter chew cycle and mill with, at the time I was using 20-degree teeth fresh out of school, and that chew cycle wasn't meshing with the 20-degree concept. So it was knocking the plate out. So I'd look and I'd say, well, my Centric's right. My vertical is good. My freeway space is good. The denture is brand new. It fits on the gum when I palpate it. I don't know why it's loose. It's a denture, Mr. Smith. And I failed to understand and realized at the time that it had to do with the changes that I made. They had a flatter cycle because the plate was worn out. Then I put them on teeth that don't function on a flat cycle. They function on a teardrop cycle. And so that's where the disconnect was. Then I forgot that they can't feel their teeth. Then I forgot that there was a pattern there from their central nervous system that needs time to change and adapt. Oval requires more freedom in Centric. You got to watch the non-working cusps. Ovoid can have a tighter occlusion, like that person now that we saw. It can be a little tighter because that's how they function. And teardrop is more regular. So it's about 1 millimeter of freedom. So how to identify a chew cycle? Well, you can have the patient chew nonstick gum, or they can bring in some food, some green pepper or red pepper, a cucumber. That's worked well for me to just have them chew, and I can try to identify their chew cycle. Or you can have the patient speak the days of the week and the months of the year in their mother language, or by using standard numbers. So typically what we check for is clinically is I would always in a wax try and look for the aesthetics. Where are the teeth? Are the midline right? Is the smile line right? Is it on the wet and dry line of the lower lip? All of the aesthetical things. I wasn't looking at how their jaw was moving. So I've retrained my eye to look at how a jaw moves. So let's try. Boy, could you see it there at the very end. And the jaw's posturing to her left. So just on 66, where before I'd be looking for the aesthetical positioning of the teeth and are they within the aesthetical aspects, now I can look at it and say, wait a minute, what's the function of the lower jaw? And now when I set the teeth up on the articulator and using the freedom concept, I can alter the teeth a little bit and position them, because now she's going to swing out to her left more. And so I can watch everything functions over to her left, and I can make that change in the lab. So For all the prosthodontists and doctors that may be listening, or all the denturists that are listening, you can check this and then you either do it yourself or you write that down on the work order that the technician or your in-house technician is moving and functioning the teeth over to that, say, that side more. If you're not getting that information, so as a technician that doesn't get any information from the doctor, okay, two things happen. One, you can start to pick up the phone and have these critical, crucial conversations with your doctors, especially your good ones that send you regular work, in quotations. That's why I say the good ones that have to send you the regular work, your good high dollar clients, and say, look, we can cut down your adjustment rate here. Can you send me some information about what their chew cycle is? If you don't get that information, then I would always err on the side of caution and have it function for both ways. And you want to increase the freedom a little bit when you design the case, which I will explain to you. Here's a lady that was a denturist, actually, that was at one of my courses. We colored her bottom teeth so that you can see it. Watch. See her jaw move? And we got Rihanna playing in the background. Anyway, she's got a really, really strong overbite. It's got to be at least 3 to 4 millimeters of overbite on this case. Yet when she talks and functions, her jaw drops down, and then it can move and slide forward. So I colored the anterior bottom teeth so that you can see that more clearly, that we have to try and catch the functional limits. So this was sent to me. So very thankful to the doctor. This is an upper complete denture on a lower cast frame partial denture. Take a look. So he has his lower anterior teeth. Watch. They're getting him to eat. What do you see, everybody? Even a denture patient has a chew cycle. We need to set the teeth within the chew cycle. If you do not, there's a hit and slide, and the hit and slide causes all of our problems. Do you want to see that again? Yeah, Mark, show us again. Okay. See that? Now, how would you categorize that chew cycle? Ovoid, flat, more teardrop? Yeah, it's more teardrop, but it's there. Okay. Watch this. Look at this. She's just going to open and close for me. Okay. Look at how, when she opens her mouth, look at it angles over to her right. So what do I have to do? Whoops. So if you look on the screen on your left side, you'll see that I have way more buccal overlap on her premolars and molars on her right side than I do, say, on her left, because I've identified that her jaw tracks to that position, so I've set the teeth to that. So this is food for thought for everyone, and especially for the dental technicians, because when you don't get to see the patient, yet the doctor's phoning and saying, well, we're having trouble with the case, and you can start to offer these ideas to help troubleshoot the case. We need to see the patient, we need to see their chew cycle and identify their chew cycle. The chew cycle interferes and influences tooth interaction. You have to modify the teeth to the chew cycle. That's another aha moment for me. So now I'm taking the teeth and I'm going to make them work within the chew cycle of a person. And if I can't determine the chew cycle, then I'm going to guess with the available information that I have on hand to make an educated decision, but always more is better than less. Remember, you do not chew in Centric. You don't chew in Centric. But Mark, my bite's right. My bite's right. Yeah, my bite was right too when I started. And again, the first 5 or 10 years of my profession. Oh yeah, I checked the bite. The bite was right. What did I forget? You don't chew in Centric. You don't. And then I set the teeth up on the articulator and expected that how the teeth were set on the articulator was how they were going to function in that person. Wrong, Mark. It wasn't like that. And now my aha moment again was to understand that how it functions on the articulator isn't necessarily how it functions in the mouth, and I needed to adapt. So this was about me changing and adapting and altering myself to that patient. So this is what it looks like. So what do we typically do is we take an articulator and we do this, right? And I'm looking for working and balancing and I'm checking everything. Yeah, and this is how we're supposed to do it. This is what we've been taught since the 50s or the 40s about what we do, okay? This is how we're supposed, this is how we do it. See, there's a song to everything, okay? All right, this is what I want you to do, okay? Oh, next video. This is what I want you to do. What am I doing to the articulator? I am simulating a chew cycle. And I am simulating what I think. Look, I can do more ovoid. I can do more flatter, more horizontal. And what am I trying to do? Catch the hidden slide. And I'm trying to then modify the teeth. So these are VITA lingual forms. And I'm trying to then catch it so that I'm not going to have that interference. I've started to change how I manipulate an articulator, because now that you've seen the chew videos, everyone, and you've seen the varied chew videos or the function, the chew cycle videos, does anybody, well, hang on a minute, bear with me. Out of those videos of people eating, did any of them function like that? Did you see anyone function the way we set up teeth in the lab to function? No. Did they? What did they do? How did they function? So start doing that in your office. Another aha moment for me. I manipulate the articulator. Now this is a Cavo Protar articulator. Look, I've done it on hinge articulators. Doesn't matter. You can learn to manipulate an articulator more like a chew cycle. Now this is the close-up of it. So what am I trying to do is catch the hidden slides. See, you can see it hidden slide. I'm trying to catch that in the office and work within the chew cycle. See there, I don't have the hits and slides. And I'm trying to, now I do. So I'm trying to, again, catch these and eliminate them and watch for them, okay? That's what I'm trying to catch now by redoing or changing how I manipulate an articulator. This was the big aha moment for me, okay? Let's look at another video. Watch this patient. You see her jaw move? Look at that sucker move. Look at that, hey? Now I'm gonna show you this and go, that's the denture I made for her. Look at that. I have what? 4 to 5 millimeters of overbite on this thing. Look at that. I have 4 to 5 millimeters of overbite, okay? Yet I cleared it and I have freedom in movement and I set to this chew cycle. So let me back that up. So when she talks, you don't see the 4 to 5 millimeters of overbite that this thing has, where her front teeth bury into the bottom way down here. 30 years ago, if I went to myself and said, Mark, you're going to build a denture with that much overbite on it, I'd say, you're crazy. You can't do that. It has to be 1 to 1 or 2 to 2. Yeah, look what I'm doing. So that's her cycle. And now I'm able to set teeth that are buried with that 4 to 5 millimeters of overbite, and the case works. Why? Because I've challenged myself and I've challenged what I think I believe. And that's what I'm doing here for everyone, for all of you y'alls that are tuned in. Challenge yourself. It's hard to let go. You got to get out of your way. And my wife said it right. I mean, I love you, Robin. She's like, Mark, you got to get out of your way. And it's hard to do, you guys. It's really hard. You have to just let go. And this is about the patient, not about you. Okay. I want to show you just a couple quickly things. I did a side-by-side edentulous upper and lower. I did a digital and a traditional side-by-side. So I want to show you a couple things. So it's a traditional and a side-by-side digital case for the same patient because I wanted to see the differences in technologies, but again, exploring the freedom concept between the both. And that's what I want to highlight here. So we had to do the digital denture a little bit differently than we did the traditional denture because the software wouldn't allow us to line up the teeth in the same way that I could manually or traditionally. So digitally, what happened is on a standard setup, this is what we try to do. The red dots are the contact points. So that's the main cusp that closes in. The black dot is the central fossa in the lower. And then the green dots are where I want freedom, where I don't want that hit and slide to occur. So on a crossbite setup, it's reversed. Okay, so it's in a different location. So the upper buccal becomes the main chew, the main chew or the pulverizing cusp, and it changes. So now with that understanding, I have to make this work for the patient. So the beauty of the freedom and having teeth that incorporate freedom in Centric is that I'm able to adapt to the patient easier than I can using 20 or 30 degree teeth. Once you cut them, they're hard to change, they're hard to adapt, they're very rigid in terms of how they function with each other. So what we had to do here actually is we ended up dropping a second molar so that we could make this, because it's a class 3 bilateral crossbite. So we ended up dropping the second molar on the upper to make this thing work. So if you look, you've got the full complement of teeth on the bottom, but on the upper, we have one less tooth. So we dropped the second molar because the software allowed us to do that. But then what that did was that it changed the occlusion. So I'm going to show you the digital aspects of it because now you can see what we did was now on the highlighted red spot, I have a second bicuspid or a second premolar in the central fossa of the lower molar. You can do that with freedom concept teeth, such as Lingoform or Vigo or Vionic. We can do that with these types of teeth because they'll still function. Even though it's not a upper molar corresponding to a lower molar, you have the freedom to do that because the teeth are free, which allows you more freedom and flexibility to adapt to the individual needs of that patient. So this isn't a cookie cutter denture. This is a customized functioning proper denture to that patient. And I'm able to do that. And look, we even have a cuspid now in the fossa of the lower premolar. So it's the upper cuspid acting as a contact point into the fossa of the lower premolar. Why not? If that's what we need to do, the tooth concept gives us the flexibility to do it, and it'll still function within the chew cycle of the person. So you can see now on the right-hand side of the screen, when we do a cross section digitally, even though it's in crossbite, it allows us to function within the chew cycle that I deemed for that person. So this is what the freedom concept did for me. It allowed me to say, wait a minute, so long as I put a cusp in a fossa and I make it function to the chew cycle of the person, it doesn't matter what cusp goes into what fossa, because aesthetically it'll still look okay. And so I thought, okay, so I did these things. And I did it, so then watching there on the screen, you can see where we go and the red lines, again, follow the chew cycle of the person. We can make it work. So I thought, okay, I'm going to insert these dentures. And I inserted the digital denture first. And when we do digital dentures, for those of you that haven't tinkered with the technology yet, we can locate all the undercuts and block them out ahead of time. So typically on an insert, I would use pressure indication paste to insert dentures and look for undercuts and pressure points. So we can do that all digitally now. So I popped these dentures in this guy's mouth, literally popped it in, gave him an apple and turned the camera on. So these have been in his mouth for 15 seconds. And he's eating an apple. And does it look like it's going all over the place? He's eating an apple. So with that said, what's important on the technology is that you identify the chew cycle. And you can see here, I snapped a picture where you see the midlines off. I'm not really concerned about that because he has that freedom, that flexibility to not land in centric accurately every time. And that's okay for me, because now that's working with the freedom concept. The second case I wanted to show you was more of a conventional class 1 case. We did, again, digital and conventional. He had a fairly standard chew cycle by identifying the days of the week and months of the year. So I could just set things sort of in a normal position for him. The denture teeth from VITA come with 1 millimeter of freedom outside, or right from the factory. So we had a couple, the traditional is because I set it by hand, where the digital lines up everything, with the computer. And so we built it. And the cross section here again shows you the cross section at the premolar range. So on the left side of the screen, you'll see the blue line running from the top to the bottom. And that's the cross section that you see on the right-hand side of the screen of the premolars. So I'm checking to see how much or what the teeth are doing, so that the cusp is in the fossa, and I'm checking the buccal positioning of the upper buccal incline. So I'm trying to make it work within his chew cycle, okay? And here's what he had to say after. So he came back for one adjustment.
Mark, for whatever reason, the voice isn't coming through.
Oh, well, let's try that again. Just a minute. Still not coming through, Jim?
No sound.
Really? Well, hang on a minute.
Good afternoon. Mark made me.
Do you hear it now, Jim?
Yes, good.
Digital ones and the handmade ones are interchangeable. I don't find any difference in either one. They're both comfortable. I've had them now for 2 weeks. I've only had to come in this morning for one small alignment, and I enjoy my teeth. I enjoy it because I can eat anything I like. I have had corn in the cob the first day I had them in my mouth, and they didn't bother me. I enjoy the fact that nobody can recognize the fact that I have false teeth. In fact, some people are question whether I do have them. And it's just something that makes me feel really comfortable. Thank you.
So this is about patient care, and this is about getting out of your way.
This is about patient care, and this is about getting out of your way. And this is about adapting to the person, and then using product that allows you to adapt. I've let go of the 10, 20, 30 flat concepts of denture teeth. I've let go of all of that. That's from the 50s. I've moved on, and now I'm dealing with lingualized occlusion in a chew cycle functioning to a patient. And I am telling you, my stress level has gone down. I come back from holidays rested because I'm not jumping right back into the fire at work anymore. It's been an eye-opener for me to, again, challenge myself. So VITA teeth are designed like a mortar and pestle, and most other denture teeth are designed like a mill. And that's the issue here, is that VITA teeth are there to crush. I have eliminated the complaint of I cannot eat lettuce or salad from my office. I've eliminated it because, again, you got to crush the fibers of the lettuce of the salad, and milling doesn't do that. Milling doesn't crush the fibers and break them apart. You have to crush it. Milling only squishes them. And that's why people always complain about eating lettuce early in my career. And now I've eliminated that. And that's what I want to share with you. Look, we are, again, we have, it's in our head. You have to have working and balancing occlusion. So on the left-hand side, you've got the working side, you come up, and then on the other side, it balances. But you have to appreciate, for that to work on an articulator, it works fine. But do you think that's how it works in the mouth with food in there? And now you're expecting both condyles to have the same function, the same shape, so that those teeth will function and the right side and the left side hits at the same time all the time. When you can't feel teeth, there's no nerve. And we don't know if the muscles are working at the same time. We don't know if the condyles are at the same condylar angle. We spend all that time making it and monkeying around on it on an articulator to make it work. And then now we expect that in the mouth. I'm getting excited because that was the frustrating part for me at the beginning part of my career till I realized, Mark, working in balancing occlusion doesn't work. It can't because this doesn't work in balance here. You're expecting that to happen. It doesn't happen that way. And now with a patient and the videos I've showed you about the chewing and how it's working, it doesn't work that way. We have to let go. God, I sound like Frozen. We have to let it go. And so that was the eye opener for me in my aha moments. And now why I'm here sharing that with you, because as a custodian, I have a responsibility now to get back to a professions that I love. I love what I do, and I'm trying to make it better, not just for me, but for all of us and our patients that trust us, because I realize I can give them more. And that's what we're trying to do here. So it's impossible for that. So here's the raw cost of our problems. An average adjustment rate for dentures is 2 to 5 times. So what does this mean? They're back in your office 2 to 5 times for an adjustment. Most adjustments can be anywhere from 20 to 30 minutes in length. You have to get them in, seat them, figure out what's wrong, do the change, release the patient, clean the room, and chart what you did. Let's face it, 20 to 30 minutes, okay? If you make and charge, if you charge, say for example, $2,600 for a denture, say the lab component of that was $700, the office has a subtotal profit of $1,900. If your overhead is running at about 75%, the office made a profit of $475. The patient comes back for 2 adjustments based on about $100 an hour billing rate for the doctor, or in some cases, if the assistant is adjusting this, you are starting to lose money based on a 30-minute adjustment. And now it's actually less if you consider the room cleanup, because you're using cost of chemicals and such to clean the room and everything. So adjustments are expensive. There is a dollar component to this. And how many adjustments do you do? 1 adjustment a day at, say, 30 minutes is 2.5 hours a week. That's 10 hours a month that you work for free. I have been around enough now lecturing and have had enough conversations. I have seen adjustment rates for a dental office. There was a dental, anywhere from 150 to 200 adjustments a month. I have seen and have been told to me dental offices that are doing 24 adjustments in 2 hours. What is the drain on 1, your resources, 2, your mental health and that of your staff? Burnout. If we get a control of that and bring that adjustment rate down, do I not have your attention? We have to let go. I sound like Frozen again. We have to because I'm from the Great White North. We have to let go of this. Stop using technology from the 50s. Get with it. Use your articulator and make it more an emotion of the patient. Use teeth that follow that motion and allow you to adapt to it. Make those changes. Drop that adjustment rate. It's costly. We can become more efficient. Freedom and Centric reduces all of the issues that I said at the beginning of the presentation. It reduces stress, damage, saves effort, stress. Preventing an adjustment is a really big deal. I've met enough practitioners now that have had very candid conversations with me. Burnout is real in our industry. It is real in our profession. You burn out. Let's get a hold of this. Whether you sit on the bench and you're doing the dentures day after day, but then you're getting the stuff back to fix. If we can get a hold of that, or the practitioners, or the wet-fingered guys that are listening, and ladies, we all have to get a control of an adjustment. It's going to make our patients happier and it makes us happier. And that's why you should care. Freedom and Centric. Why should I care? This is about care for your patients and it's about self-care. So what are your takeaways? Why did you become a denturist or a doctor or a prosthodontist or a technician? Recognize and remember that joy of what brought you to this industry. Recognize burnout symptoms and what are you going to do to manage them from at least the denture perspective. We're going to have a whole other conversation about your personal life and everything else to reduce stress, but let's do it for what we can do here in the office. Freedom and Centric in traditional or digital dentures. What is it and why is it there? We forgot about it. Start using it on denture teeth that incorporate it and follow the chew cycle of a patient, how to identify it, and now how to modify teeth to it. The cost of an adjustment. It's expensive for us because we're not making money during those adjustments. We're tying up staff for those adjustments or myself for those adjustments. We're not doing revenue work. I mean, honestly, 24 adjustments in 2 hours? You don't think you go home tired or your staff goes home tired after that? Do that day after day and week after week. You wonder why you burned out? We have to get control of this. Be a superhero to yourself and your patient and use Freedom and Centric teeth. This is important. So I wish to, and VITA wishes to further support our relationship with you. So seek out further courses at VITANorthAmerica.com under education. Jim will also give you information. So this is my information and he'll post that again. So if you're looking at the recording, you can stop, get a hold of me, text me, email me, but just allow me some time to get back to you. I'm here to support you. Okay, so that's first and foremost. And you got to understand how it's about learning to get out of your way. Here's the territory list for the VITA reps as well. So they're there to help you. Okay, and I want to now switch over, so bear with me. And we're going to go to a document camera because I want to show you a couple, whoops, yeah, there we go. I want to show you a couple things. There it is. It went on the other side. Okay, camera. All right. First off, VITA publishes this, so this is the mold guide. So you can ask your rep for this. So this talks about all the teeth and the molds, etc. Okay, so that's what you can do, and you can get that from your VITA rep. Okay, because the SKU number is right down there, so they can get that ordered for you if you wish to peruse through this. Okay. All right. So I'm going to pull out my articulator, but remember, I wanted to again show you this in real person. We don't do this anymore. I want you to lift the articulator, regardless of what it is, and facilitate a chew cycle. And that's how you should start to manipulate and use the machine to your advantage. The articulator is a machine. Let's use it to your advantage of how it works. The next thing I wanted to show you is this. Okay. All right. Okay, so denture teeth. So we've got the larger cusp. So lingualized occlusion. Some people get a little antsy on it because they think that, well, if it's lingualized, what's happening is that you have to tip the buccal cusp down, or the buccal cusp is up high and they don't like that look. We actually can have a lingualized occlusion with the buccal cusp down. What's important is that freedom and centric. So it's allowed to rock and centric. So when you go through the chew cycle, what we're trying to do is eliminate the hit and slide into position. So these are built with overlap, so you don't really see the lingualized concept. It's not as stark as like what we had to do in the old days. The old days for lingualized occlusion, I remember I took a Pilkington and Turner upper, and everyone's nodding their head, and then I took a functional tooth on the bottom and hollowed it out a little bit, and that was lingualized occlusion. But of course, then you had to tip this, And then we didn't like what that looked like. So now everyone, we can drop it down and you don't see it as lingualized. Yet it functions as a crushing tooth, as a mortar and pestle type of approach, and functions within the chew cycle of the person. Then if I want to adjust it, what I do is then I gotta grind the guiding planes here and widen it. So what happens is out of the factory, I have about 1 millimeter. But if I grind these guiding planes, then that gives me more. So if I start grinding this away slightly, that gives me a larger zone to land in. Why would I want to do that? Well, on that patient with the more horizontal chew pattern from a denture that's been really worn down, that they've been wearing for 20, 30 years, they're going to have more of a milling type of chew pattern. Then I can go in here and grind it. VITA teeth are awesome because I don't have to polish them. They're acrylic glass. The glass self-polishes. So on other acrylic teeth, then I got to go in here and I got to polish this after so I don't leave it rough. I don't need to do that on VITA teeth. So again, this is using product that helps me make my life easier. And that's why I follow this and have fallen in love with the teeth, because they work for me and now my changed philosophy of treatment care. So that was the first order that I wanted to show you here, was the chew cycle. We can hide it. We don't have to make it look like a standard lingualized occlusion. The cusps are hidden and the teeth are designed so that they have the wiggle room and they function. So that's the beauty of this, okay? And then if I need to adjust, I can adjust on the guiding planes. And sometimes I have to go up here or even here, depending on the case and the situation, to make that work for the patient. Okay, one of the last things I wanted to show you as we're slowly wrapping up is, and bear with me as I hit focus. Does that look familiar to you? There's our good old 20-degree teeth, okay? Designed from the 50s. We're gonna lay that on the denture. So what I did to facilitate this on a learning model was I cut out the flanges and stuff to facilitate this, so you can see this more. So let me hit focus. Okay, now I'm going to open up the one condyle of the articulator, and then what do we do when we check is we check working and balancing. So this is what we're taught in school, is I'm supposed to check this. Now, so I'm getting working and balancing occlusion, but now draw your attention to what you see happening right up here. Can you see that move? Now you're saying, well, wait a minute, Mark, your working and balancing occlusions isn't working. And I'm going to say, yeah, I've checked this. I've used the paper. I've used articulating paper. I have proper working and balancing occlusion on the articulator. But then you're going to say, but Mark, you've cut the flange away. Well, bear with me on that one, okay? I'll give you credit there to say, well, I've cut some of the support away. But what I wanted to show you was, even though I've checked it, okay, it's going to rock a little bit. And now you imagine that's just on the articulator of what we've done in the past. Now, what do I mean by that? Now I want to take it and I want to go through a chew cycle. And what happens is you can see that the denture is wobbling, because again, how I do the chew and how I make the teeth come down and touch can't be the same every time, so the denture wobbles. And this is what the problem was of why we get the sores, why the patient would say to me, well, how come the new one fits worse than the old one? All of our chipping and these issues come back to this phenomenon of now in a chew cycle with everything functioning, the condylar angles, the muscles, everything, the denture tips, and it tips enough that it rocks. And the rocking was caused by the hit and slide. So now these are lingoform. So now into this pattern, because now I have freedom in Centric and I have that little helicopter pad to land into, what happens is when I do that, the denture doesn't rock in the same manner as what it did before. And so I appreciate that this is hard to see on a video. So I'm apologize for that, but I wanted to show you that I've made these types of educational assistance, especially in hands-on courses, to show you that once you start to move this, it's going to rock. When you have that freedom, then what it does is it plants the denture down more and it creates that stability so that it's not moving. Because remember I said the hit and slide, what was causing us the damage, the hit and slide was the mother of all of our problems here before. And once I understood that and understood the hit and slide causes the problem, then I made the steps and my growth journey to try and identify how that happens and why. Because then on an articulator, both condyles are set the same, everything's perfect, yet this isn't, and this doesn't function that way. So if I can identify that, and even if I can't identify it, I still can make the changes here. So what have you heard me say? I try to give more freedom, do more than less when you don't know. So you try to move the articulator and change everything and get everything in motion for that patient, even though I didn't get the information from the doctor necessarily. I can still make those corrections in the lab, not using up a lot of time. Your technicians can still go and through this, and they still have production standards and goals that they can meet, because what I'm showing you doesn't take a lot of extra time. They're easy set teeth. They find their centric quickly. All you're doing then is self-adjusting the articulator, making sure you catch the little guiding planes. So as we slowly move back to in-person learning, we can meet with you and talk about this and show you even more. So I'm going to bring Jim into the fold. So Jim, do we have any questions? Because we are slowly finishing our time and our journey.
We do. And before we get to that, let me show you, go over a few things, last minute questions that we always have during every webinar. So let's go over some of those first.
Yes, I'd like to wait.
And part of it is the CE. That's always a question that we have. So the CE is going to be emailed to you through your registration of today's webinar. So Mark did a great job, and that will be posted. The recording of this program will be posted on our social media YouTube channel, VITA North America YouTube channel. But again, your CE will be a follow-up, will be sent through your registration of today's webinars. And then Mark had mentioned it about the sales reps. If you need to contact Mark or sales reps here at the office itself, you can also get a hold of us at our help desk line. So we can help you with any questions or guide you. This is again the list that Mark showed earlier of the reps. Please get a hold of your sales reps if you have any questions of today's program or about our VITA Denture Teeth or any other VITA material. Also look forward to other programs that Mark is scheduled. This isn't all Mark's scheduling, but we have quite a few different webinars scheduled again this year. And what's unique again this year, Mark is gracious enough we're going to try to do some 3-day hands-on remote workshops. So we're going to do, I think we decided that we're going to try to tackle, Mark, a class 1, a class 2, and a class 3. This will be a remote webinar in which we would send you some model work, some denture teeth, and then we will work with you. Mark will work with you for 3 days. Each day is 2 hours long, so we don't keep you from your work. But it's a series, a 3-part series, that goes into the treatment planning, into the setup and theory, and everything that Mark's described today, he'll incorporate into an actual hands-on where you can follow Mark during the setup phase. There is a fee for this particular workshop. It's very minimal, but please look into that. We'd be happy for you to join us, and it's really nice. While we can't get in-person workshops yet, it's soon. I know it's going to be soon. Things are changing, but until that time happens and we can move about from Canada into the U.S. and vice versa, we're going to do these remote workshops. So please join us for additional webinars with Mark as well.
I'm going to put you to work.
Yeah, we'll put you to work, and but it'll be fun. Mark does a great workshop program. So if you want to find out more, visit us, vitanorthamerica.com/courses. Mark showed this earlier, his information. So I'm going to leave it there, and then we'll get to the any questions we have. And so let's start off with.
Here to help and support you guys.
Yeah. So we have one that is the red and black green marks. You know, where you illustrated those.
Yes.
Those are really, what was the concept in that? There you go. Do you want to show it on your camera? I can make you the presenter and then bring you back.
The whole purpose of that was, from an educational perspective, was to highlight the cusps and what each cusp does. So from an adult learning perspective, when adults have to go through education, we have to do 4 types. There's 4 types of adult learning. So we have to do show, tell, do, review. So what I came up with was, I came up by using these non-permanent markers to dab on the teeth to show you what each cusp does in relation to itself and its correspondent. So the black was the fossa that accepts the upper cusp into it. The upper cusp was in red. That's the crushing cusp. So the black is the holder, the upper is the crusher. The green was when you go through the chew cycle. That's the guiding planes. And those are where you don't want the hidden slides to happen, because that's the hidden slide area. So then I color it in green, and then I go through the motion of the articulator, and then the colors will mark off on their antagonists, and then I can self-adjust it as required. So that was the idea behind the concept behind the markers. These I use in the lab, so laboratory. I don't use articulating paper anymore in the lab. Did he just say that? Exactly, I use this. And then in the clinic, so clinically I can show you as well how to check that, because these are non-permanent. So if I put this in the mouth, they'll bleed out. The saliva will wash this away. So I have a procedure in place that I do for clinical applications. But this was to, again, identify from a learning concept position about what the cusps do and why. But I only had you for an hour and a half. That's why you're going to take the 2-hour, 3-day course, so that we can really hammer it in, so I can show this to you and then you get it better. This was to do what? Tempt your tummy with the taste of nuts and honey so you come back. And then when we could do this in person, you can come to a course. This is about me supporting you, and this is about me supporting your patients that trust you. Regardless, again, your position in the family unit of dentistry, from a technician to a doctor or what, this is about supporting our patients. So next question.
All right, well said. All right, so the patient that you showed with the 4 or 5 millimeter overbite, can you elaborate on anterior, posterior balancing, the context during the excursive and protrusive movements?
Yeah, so that was a really good example of getting out of your way. So I had to get out of my way going, I can't build a denture like that. Yeah, Mark, you can. So what I did was I had the overlap there. So it's not a straight plane of occlusion. There's the anterior bottom teeth are up higher than the posterior teeth, but that's what it needed to do to function. But when she opens her mouth and speaks, you don't notice that. So that's where I was able to change myself to her. So the case does look a little funny. It's got the really strong overbite to it, but functionally in the back, it's not a level setup, because it doesn't have to be, because what I realized is with freedom and again, setting the teeth with freedom in movement and the concepts, I was able to challenge myself, challenge what I believed, and set it up for her. So to again show you that she had the overbite, but posteriorly it wasn't. It's not a smooth setup. The anterior teeth are up higher than the plane of occlusion of the posts, but it works.
All right. Another question is using a face bow. Using a face bow, is that paramount to achieving the freedom of Centric, freedom of movement?
Okay, so no, that doesn't have to. Face bow does not have the bearing on the freedom. The freedom is built into the condyles, and everybody has some way, shape, or form. So that freedom is not derived from the face bow. That's derived from the temporomandibular joint. What a face bow does is it arcs and cants the upper model in relation to the hinge access point of the articulator. That's what that does. So it's helpful because what we're trying to do is correlate the correct angulation of it functioning within a chew cycle, but it does not affect the freedom. The freedom, that's a different factor of it at all, but the face bow or a Digma, for example, the digital face bow would cant the model accordingly so that I'm closing that error of the cycle, of the chew cycle and the arcs and angulations associated with that.
How does a face bow compare to the Cavo average value jig?
Okay.
Are you familiar with that?
Yes, I am.
Okay.
So yes. Okay. So a Cavo face bow is actually called an ear bow. So most face bows have a little round end and it goes right into the ear. What Cavo did was their earpiece has a little crook on it, so it goes into the ear and then you actually pull it forward, so the end piece is actually pushing against the back end of the condyle. So it's trying to close that error and that gap error. Then you take the face bow. So when I use a Cavo face bow, you should actually be able to wiggle your head and it not move and not come off. When you're done, there should be a welt here because it should fit that tight on the patient. Because the tighter it is, the less issues of it rocking and giving you a wrong reading. Face bows or ear bows can be upwards of 6 to 7 degrees off or 6 to 7 degrees margin of error. What an average value jig does is it uses anatomical landmarks of a model. Now, forgive me, I don't have my jig handy here. I'd go get it. What the jig does is it uses anatomical landmarks. So it's using the hamular notch of the models and either the incisive papilla or the 22 millimeters of the sulcus of the upper. And the average value jig is going to do this for you using the anatomical landmarks of the model if you don't use a face bow. So there are different ways of trying to get the same thing. It's trying to cant and arc the upper model as it sits in the skull in relation then into the articulator. The reason why we're using anatomical landmarks is because we are golden proportion, which means mathematically speaking, everything in my skull is mathematically equated to each other. I know. I'm 52. I should have paid more attention to math 30. Anyway, everything is golden proportion. This was another aha moment for me to realize this. This thing is golden proportion. So when they use an average value jig, it golden proportions this within the articulator to a similar concept of the face bow. They're just different ways of achieving the ultimate end goal of canting the model, the upper model. Okay?
All right, we're coming up on the hour and a half point. So last question. So there's a statement first, but to identify intraoral interference, this technician tried to paint ink from articulating paper onto the cusp
Yes.
with the Q-tip Vaseline method like you show.
Yes. Yes.
The ink isn't transferring well. Do you have any tips, or are they missing a link?
So have I tried different aspects. The ink still works the best for me. So here's a couple of things. The denture, when you take it out of the patient's mouth, you have to clean it a little bit. So what I'd like to do then is you should disinfect it, and then you should throw it in the ultrasonic cleaner to take off any residue or resin that could be on it from the saliva or food or whatnot. And then it has to be really dry. And then you take the Q-tip and a healthy amount of Vaseline or petroleum jelly, and you transfer that ink, and then you can transfer it on. I do apologize. Sometimes it also has to do with the type of articulating paper you use and how that ink transfers to the Q-tip or the cotton swab and then on to the denture teeth. So I've tried different types of articulating paper. So right now, the one that I find that works well is from Horace Kulzer. That's worked well for me for transferring. So you might have to, again, borrow some different articulating papers from other colleagues if you can, so you don't make a lot of investments in different types of articulating paper. But you got to try it and see which one works. You're on the right track. Keep going. But remember, it's not going to paint on like if I colored it on. It's going to be a little lighter of an application, but it's still there and it'll still work for you. It works for me. It'll work for you. You just try some different articulating papers and make sure that denture is clean and dry, please. And then get back to us if it isn't, or now that you have my contact information, contact me directly and then I can help you even more. So thank you.
All right, Mark, I really appreciate it. Wonderful information as always. A reminder for everyone that we have plenty of webinars for 2022 with Mark. Different, we're getting, like I mentioned, we're going to do class 1. We're going to go back to different class 2, class 3, against natural dentition. So we've got a lot of concepts that we're going to roll out this year, plus do some of those hands-on remote workshops. So I want to thank you very much, Mark, for your time. Any last words you'd like to get with us?
Thanks, Jim. Thanks, VITA, for supporting us and for supporting our professions. And we are here to support you, and I am here to support you. Thank you for investing in yourself. Woot, woot. We don't slap teeth together. Woot, woot. And this is about getting control of your own health and self-care, and then that of your office and your employees, and then that of the patient. So thank you for investing in yourself on that and in your own mental health to get a hold of that burnout phase by trying to, again, get out of your way to understand some of the concepts I'm speaking about, because they are different. It's taken me now my journey to get out of my way to where I am today. So thank you for that. Thanks for challenging yourself and challenging what you think you believe and being open to the change. It's really hard, but you're doing it for good reason. So thank you. And thanks again to VITA for their kind support.
Well, thank you, Mark, and thank you everyone that joined us today for this VITA Learning webinar. I hope to see you again on a future one. And with that, we will say goodbye to Mark and the rest of you. Stay safe and stay well. And this will conclude today's webinar with Mr. Mark Wagenseal.
Bye.